In this lesson, we will be covering Chapter 4 in your reimbursement textbook. Chapter 4 is government-sponsored healthcare programs. Some of the programs you will more than likely have heard of, and some of these will probably be new to you. The objectives in today's lecture include understanding the differences among and identifying the various government-sponsored healthcare programs that are in the U.S., the history of Medicare and Medicaid in America, and understanding the impact that government-sponsored health programs have on our healthcare system. The Social Security Act was amended in 1965 in order to create the Medicare program. Most of you probably know what Medicare is or know somebody that's on Medicare. Medicare is basically a nationwide health insurance that provides health services to the elderly and to other qualifying persons. Medicare benefits are also available for those people that are entitled to Social Security or railroad retirement disability benefits for at least 24 months, government employees with Medicare coverage who have been disabled for more than 29 months, insured workers and their spouses with end-stage renal disease, and also children with end-stage renal disease can be covered under Medicare. In 2010, two major laws passed that really had a big impact on the Medicare system. The Patient Protection and Affordable Care Act was enacted on March 23, 2010, and the Healthcare Education Reconciliation Act of 2010 was passed on March 30th of 2010. So together, those two laws combined are known as the ACA, which we talked about last chapter a little bit, or the Affordable Care Act of 2012. This basically outlines some provisions that are related to Medicare, and several of those will be discussed throughout the textbook, and in this chapter we'll look at some of that as well. Medicare Part A is basically our hospital insurance. It covers inpatient hospital stays. It is provided with no premiums to most beneficiaries. Most services are covered under this benefit. They do have a yearly deductible and co-payment that must be paid by the beneficiary. Services that would be included in Part A include, as I said, inpatient stays, your long-term care hospitalizations, skilled nursing services, home health, and hospice. Table 4.1 in Chapter 4 of your textbook does outline some Part A services, and the sites, the benefit periods, what the patient's responsible for, so you can review those to kind of get a broader idea. Medicare Part B insurance is a supplementary insurance. It is optional that beneficiaries can purchase if they choose to. In 2012, the premium per month was $99.90. Basically, Part B would cover physician services, medical services, and medical supplies, or basically the bulk of what is not covered under Part A. Most of these things are provided on an outpatient or ambulatory basis. In addition to that monthly premium, patients are responsible for a deductible and for co-payments. There is also a table in your book, Table 4.2, that outlines Part B services. Because some items are excluded from Part A or Part B coverage, beneficiaries can go ahead and purchase additional coverage or choose Part C, Medicare Part C. also known as Medicare Advantage if they choose the Medicare managed care option in order to get insurance. What's covered under Part C that are not covered in A or B would be long-term nursing, home insurance, care, custodial care, dental, vision, routine exams, wellness, acupuncture, hearing aids, those type of things. Medicare Part D is what we call our drug benefit, and it was created in 2003 but fully implemented in 2006. What this program does is offer outpatient drug coverage provided by private prescription drug plans and Medicare Advantage. Beneficiaries pay a monthly premium that varies, but it can be as low as $15 a month. In addition to that, beneficiaries, they also have a deductible that they have to meet each year and co-payments with their prescription. Medigap is a supplementary insurance as well, and it covers most cost-sharing expenses, as shown in those two tables that I just talked about. Those policies, they have to meet federal standards offered by the different insurance companies, the private policies that patients can pick up. Originally known as the Medical Assistance Program, Medicaid was added to the Social Security Act in 1965. It is a joint program between the federal and the state governments to provide benefits, healthcare benefits to low-income persons and their families. So basically, the key to remember, it is a joint program. It's not completely run by the government. It is not completely run by the state. It is administered by each individual state, so each individual state can develop and maintain the unique program to their state. They will each determine what are the eligibility requirements, what services will be covered. So for that reason, coverage between states, state to state, is very, very different. A person that qualifies in one state may not be covered in another state. For a state to qualify to receive these Medicaid federal funds, the state's program has to provide coverage for at least these groups here: the low-income families with children, supplementary security income recipients, infants born to Medicaid-eligible moms, children younger than 6 whose family income is at or below 133% of the federal poverty level, recipients of adoption assistance and foster care, certain Medicare beneficiaries, and our special protected groups. The Personal Responsibility and Work Opportunity Reconciliation Act of 1996, also known as welfare reform, brought a lot of changes to Medicaid. So, for example, welfare reform repealed aid to families with dependent children program, and it was replaced with the TANF program. Basically, this provides states with grant money that's designated to provide low-income families with case assistance. The PACE program is a joint Medicare-Medicaid venture that offers states the option of creating and administering capitated managed care options for the elderly population. PACE was basically designed to enhance the quality of life for those frail elderly, that allows them really to live in their own homes and communities and try and preserve and support the family unit. Beneficiaries of the PACE program, as we talked about, they're frail elderly persons, but they have to meet certain requirements as well. They have to be at least age 55 or older. They must be a resident in a designated PACE service area. They have to be assessed by a PACE team, and they have to be certified by the state agency as eligible for nursing home level of care. So they have to be frail enough to be on that level of care. CHIP was created in '97 by the Balanced Budget Act. It was renewed and strengthened through the Children's Health Insurance Program Reauthorization Act of 2009. Basically, CHIP is a state-federal partnership that targets our growing number of children that are not covered by private health insurance. Since it was created, CHIP has provided services for more than 40 million children, so a very, very important program. It's designed to provide insurance for children of families whose income is too high to qualify for Medicaid, but it's too low to be able to afford the premiums and costs associated with private health plans. Like Medicaid, CHIP varies from state to state. Each state has to determine how it's going to deliver the benefits and all those pieces that come into play there. States have to provide the following services to CHIP beneficiaries: inpatient hospital stays, outpatient hospital services, physicians' medical and surgical services, lab and x-ray, well baby child care, including immunizations, and dental. The Department of Defense provides health care programs for active duty and retired members of the 7 services of the United States. Those are Air Force, Army, Coast Guard, Marine, Navy, National Oceanic and Atmospheric Administration, Commissioned Corps, and Public Health Services. So also, coverage is also provided for families and their survivors. The program is now called TRICARE. It used to be called CHAMPUS. So things changed in 1966 with amendments to the Dependents Medical Care Act. Medicare provides comprehensive coverage for all beneficiaries, includes outpatient visits, hospitalization, preventative services, maternity care, immunization, and mental health services. All active duty service members are covered under one of these TRICARE options. TRICARE Remote or Prime Remote is required when the service members live and work in remote areas. So in this option, the members may have access to primary care from an out-of-network, and the providers are unavailable in their area that are in-network. There are no enrollment fees, deductibles, or co-payments for services and prescription with TRICARE, Prime, or Prime Remote. The TRICARE Standard and Standard Overseas, this is basically the same concept as Prime and Prime Remote, but these active duty or family members are located overseas. The TRICARE Young Adult, this is a plan option available to young adult children of active duty service members, reserve members, and military retirees. Someone would qualify if they are a child of one of those persons just mentioned. They are between 21 and 25 years old. They are unmarried, and they're not eligible to enroll in an employer-sponsored health plan tied to their own employment. The TRICARE Reserve and Retired Reserve. Basically, the TRICARE Reserve is a premium-based health plan that qualified National Guard and Reserve members can purchase. They're individual plans or a family plan. They pay a monthly premium. There's a 15% coinsurance for outpatient and 20% coinsurance for out-of-network providers. The retired reserve plan is basically the same, except there's higher premiums, higher coinsurance, and co-payment amounts. TRICARE for Life is available as a secondary insurance, secondary to Medicare. Members are required to participate in Medicare Part B and pay those Part B premiums. Basically, the TRICARE for Life is going to help lower the out-of-pocket expenses that the beneficiary pays. The Department of Veterans Affairs provides covered healthcare services and supplies to their eligible beneficiaries through the Civilian Health and Medical Program of the Department of Veterans Affairs, or what we can call CHAMPA. This program is available for a spouse or a widow and for the children of a veteran who meets certain criteria that includes they're permanently or totally disabled due to a service-related disability. They were permanently and totally disabled due to a service-connected condition at the time of their death. They died in a service-connected disability and or died on active duty. Persons that are on TRICARE cannot also participate in CHAMPA. This program covers most healthcare services and supplies that are medically necessary. CHAMPA would become a secondary payer when any other health benefit is available. The Indian Health Service was created in order to uphold the federal government's obligation to promote healthy Indians, American Indians, or Alaska Native people, their communities, and the culture. The government-to-government relationship between the U.S. and the American Indian tribes was established in 1787. Some of the covered services are preventative. Primary medical services are hospital or a clinic items, community health, substance abuse, and also rehab. Workers' comp is a benefit that's provided to most employees to cover health care costs and lost income that results from a work-related injury or illness. So it covers both the cost of the medical care as a result of the injury and also the lost income. It is monitored and legislated by the states that set the coverage. They also set the exclusions in specific workers. The Federal Employees Compensation Act of 1916 was established to basically ensure that civilian employees of the federal government are provided medical, death, income benefits for work-related accidents, illnesses, or death. So it provides for medical, death benefits, and for loss